bit of work to get some of these technology challenges sorted. Sometimes it doesn't work as planned, but we are just 4 minutes past the hour. So thank you all for making time to come to this webinar. I welcome you all. And we're going to try our very best to stick to the time, which is 2 hours. So the format of the webinar, so this is hosted by the niche, which is NITAG Scientific Hub, which is based at the University of Cape Town. This is our second webinar, and today's webinar, we're going to talk about COVID-19 vaccine confidence and uptake in Africa. We're going to have 15 minutes talk by Lisa Manning from WHO. And then after that, we're going to have 4 NITAGs from DRC, South Africa, and Mozambique, as well as Zimbabwe, share their country-specific experiences on the issues around COVID-19 vaccine confidence. And this will be moderated by Dr. Eves, who is going to moderate this session and subsequently take over. So I think I'm going to just let Chantel do some housekeeping, and then we can hand over to Lisa, and then we continue with the program. Over to you, Chantel.
Okay, sure. Thank you. As you noticed, we were a little bit late assigning the interpretation channels this afternoon, but you can choose which interpretation you would prefer. There's French and English by looking at the icon at the bottom of the screen.
C'est ouvert l'anglais en cliquant sur l'icône de globe qui se trouve en bas de votre écran.
And then when we have the discussion session,
quando começarmos a nossa sessão de discussão, por favor, queiram utilizar.
Type your questions, and I will alert Yves if there's any issues and help him man that chat section. Okay, over to you, Benjamin.
Okay, thanks, Chantel. Now we're going to start with the presentation from Lisa, and after that, Yves will take over, and each of the NITAGs are going to present for 10 minutes. Over to you, Lisa, please.
Thank you very much, Benjamin, and thank you indeed to Nish and the hosts of today's session.
Lisa, there seems to be an issue with your sound.
Lisa, your audio is not very, we can hear you very faintly.
Shall I speak louder? Is that better? Okay,
yes.
Thank you very much. So I firstly would like to say thank you very much for the opportunity to join your session today and to offer a perspective from WHO on the latest evidence in relation to what drives vaccine uptake from a behavioural and social demand-related perspective, but also to bring to the fore some of the latest evidence we have around the interventions that are effective in actually working to increase confidence and uptake. So in this short presentation, I'll go through some work that we've recently carried out with an expert group that developed a framework and set of tools to be able to systematically measure these drivers, but then also work we have done to identify the effective interventions that are based on evidence. So generally, in a lot of the narratives and explanations and a lot of the media reporting that we hear about vaccination, there's a very simple explanation that's offered, that there's anti-vaxxers who are spreading misinformation and rumours, and generally that contributes to eroding confidence, eroding acceptance, and it decreases coverage as a consequence and leads to outbreaks. So this is what we commonly hear, but based on a review of the global evidence and with expert and partner inputs, we've developed this framework which indicates the 4 main drivers of vaccination uptake from a behavioural and social perspective. And this includes thinking and feeling. So this is where we situate confidence and attitudes. Then there are the social processes or the social norms or influences that also shape our behaviours. And these typically contribute to guiding our motivations or intentions, our desire to want to get vaccinated. And our ability to carry through with this is then actually affected by these practical factors related to service quality, availability, affordability, how easy and convenient it is to get vaccinated, and even that experience on site at the health clinic or facility. And all of this contributes to vaccine uptake. So this framework we developed based on the global evidence and expertise, and this helps us to very specifically articulate each of these different drivers or determinants of vaccination, and to make sure that we're really measuring everything that can contribute to uptake. And this can then correspond to identifying the right interventions and monitoring and evaluation of the implementation of those interventions at a local level. So based on that framework with our expert group, we've developed tools and guidance for childhood vaccination and for COVID vaccines as well. So we have surveys with about 20 items each for childhood and COVID vaccination. But then we also have qualitative tools or interview guides that are targeted to parents, health workers, community stakeholders, authorities, because we know that getting this qualitative data at a local level in specific settings where there exists inequities and pockets or hotspots of under-vaccination is also really important. And as researchers, we know the important value of complementing survey data with these qualitative insights. And so to help with the gathering and use of this data, we've also developed practical implementation guidance as well, because we really want to make this as easy as possible for programs to know how to use these tools to really diagnose the root causes of under-vaccination at a local level. So for example, here are some of the questions that we are asking. So for childhood vaccination, a question about how easy it is to get vaccination services for your child, and breaking that down into 4 response options. And we can see that in the corresponding qualitative questions that are targeted to a health worker or a parent, these are open questions that enable us to get a richer understanding of what these issues can be. I won't go into that detail, but I can share the slides after this session, and they can be circulated to this group for closer reference on the details in some of these slides. And as you can see, we're really putting an emphasis on thinking about the contribution of these social factors and these access related issues, because when we have good data, we really see the contribution of these factors to serving as barriers or drivers to uptake. So based on our framework, we've identified priority indicators. We went through an intensive process of field testing and validating our draft tools globally in many countries to make sure that they actually measured what we expected them to be measuring. And we made various revisions to the tools, also in consultation with experts and partners and programs, implementers. And we're really grateful for all of the expertise that contributed there. And as a result of that entire lengthy process, we were able to then also identify these priority indicators. And what this means is that we have these measures that can be used on a consistent and standardized basis, so that at a local level or even globally, we can start tracking trends and being able to compare these issues to really have a better understanding of what's the main problem, but also are things improving or getting worse, depending on everything that's going on and what we're trying to achieve with certain interventions, but even other events that are taking place in various settings as well. So this is not just about gathering good data to really understand the issues. What we're also trying to do is make sure that we can guide programs to the right kinds of interventions that are shown by the latest evidence to be effective. So we carried out last year a scoping review to start to identify these interventions. And as you can see here, these are more than just informational or educational type interventions. It goes beyond social mobilization, community engagement, education of health workers, to really be thinking about the systems and structural interventions that will make it as easy and convenient as possible for people to get vaccinated. We know that a lot of this evidence for now comes from mainly high-income countries, but what we're really hoping to do is to help ensure that with the consistent use of our tools for diagnosis and with better sharing of what works in different countries around the world, we can grow our knowledge about what works to increase vaccination in more in low middle income settings as well. So based on the evidence, we've also developed further guidance that really unpacks further some of these areas of interventions. And one important one is quality immunisation services. We really know from the evidence that if services really truly meet the needs of the communities where they're located, this is a very important and substantial contribution to achieving high uptake. So we have developed some guidance for national programs that really articulates exactly what quality programs and services consist of and how to do this. We also have, with UNICEF together, elaborated on a guide for human-centered design for tailored programs. And this is really about looking at inequities, these specific communities or districts where there's low uptake, and being able to go through a participatory and inclusive process of diagnosing reasons for low uptake and working together to design and evaluate the right solutions. Again, similarly, we're just about to launch our final guidance here, and a lot more to be said on this. We also know that conversations about vaccines are really important. And in settings where there's misinformation, one of the main ways to be able to, in a way, correct misinformation is through conversations, where we really have a dialogue with people in communities, in health settings, in health services, in clinics, to be able to say, what are your main concerns? Tell me a little bit more about why you think this way, and really get through to the underlying values often that really also ultimately, we know that we want our children to be healthy and live long lives. We want that for our family, for our friends. And so to find a way to start from a common shared position about what we want in our lives and our communities, and to then build on that to recommend vaccination and to find ways of addressing those concerns and maybe referring people to others who are trusted. And organisations, local civil society or NGOs or local associations also have a really important role to play in sharing accurate information and being equipped as advocates to also break down these barriers. At a general level too, national authorities and other partners have a role in communicating effective, correct, salient, relevant information. And here are some evidence-based recommendations and learnings that we have about how to use information for change. And this particularly derives from a lot of what we've seen recently in relation to COVID vaccines and what has worked to overcome misinformation in terms of being able to use trusted information sources, to tailor messaging, to be working across multiple channels, to be targeting specific population groups, and how we measure these communication strategies as well. But from the evidence, we know it's important to ensure that accurate information is available and that we support informed decision-making. That is absolutely essential. But we know that it's not enough to help inform people. That is not enough to ultimately get people vaccinated. And that's where we really lean into all of these strategies that are situated on our service delivery or other types of community social level factors as well. So just to summarize what's needed, firstly, we need to start with a good understanding of what the actual issues are. And rarely it's about hesitancy or a lack of confidence. There are often all sorts of other barriers, particularly access-related issues that contribute significantly. So we need to fully understand those issues to begin with, then think about the services and other types of structural or social level interventions that can help influence, work closely together with our health workers, because we know in many settings they're very well trusted, work with our community representatives, allies and advocates, share accurate information and do that through many trusted sources, establish partnerships that go beyond the health sector, the education sector, the social services sector, many others, and also be working together to build political commitment to vaccination, to invest in the right range of strategies that are comprehensive to really promote vaccination and make vaccination really easy and convenient and a positive experience, and to do that in a way that eventually benefits primary care and universal coverage as well. So because I know that you have a perspective of thinking about NITAGs and the recommendations that NITAGs make in supporting programs, here's a slide 2 with a session that we had with SAGE at a global level in October last year. And this is where we presented to SAGE the evidence and outputs of our testing and validation process of our tools to measure behavioural and social drivers. And SAGE recommended the systematic use of this data. And here's a slide just summarising the resulting publications and conclusions and recommendations. And we'll also be publishing a position paper on this topic next month, in fact, so please also look out for that, and I can follow up with Benjamin and colleagues to make sure that reaches you. I'm also happy to take any questions or engage further in this topic in any other ways as well. So that's just a quick presentation. Thank you very much for your time, and happy to engage further. Thank you.
Thank you so much, Lisa, for that excellent presentation. Lisa, you're going to stay with us to have that moderated discussion, and I'm sure there'll be questions. Excellent.
Thank you.
So Yves, please take over and lead the rest of the sessions. Over to you, Yves.
Merci beaucoup, Benjamin. Bonjour.
Thank you very much, Benjamin. Good morning, dear participants. I think we followed with quite a lot of interest Lisa's presentation, and she explained vaccine hesitancy as well as the reasons that may lead to it, particularly in Africa, in our African countries. She spoke very briefly about the individual factors that lead to hesitancy. She spoke about efficiency, but she also discussed the social and societal norms that play a role in vaccine hesitancy. And she continued and concluded the presentation with SAGE's recommendations, which focused on the collection of data that could be used appropriately to issue recommendations that could be useful. We are now going to continue by discussing 4 countries' experiences. Those 4 countries are going to share with us their experience in terms of vaccine confidence and vaccine uptake. Are you following me? The first presentation is going to be made by Prof. Paul Sampson, who is the chairperson of GTCV DRC. But before the presentation starts, allow me to remind you or to give you some data. Please remember that we have a few billion doses that have been administered so far in the world, among which 400 million on our continent. And this is about 63% of the doses that have been received so far. We have about 520 million doses that have also been received, and that represented 30% of the necessary doses. 34% of the people have already been vaccinated. In terms of the total additional doses that are necessary to vaccinate 70% of the population is over 1 billion doses. To date, we only have 13% of the population that has not received any vaccine at all. Only 2 countries so far have been able to achieve a 70% vaccine coverage rate for their population. This means that we are encountering a major challenge in terms of vaccine uptake and confidence. On this note, I'm going to invite Prof. Paul Sampson from GTCV DRC so that he can make his presentation. Professor, you have the floor. You have 10 minutes. Thank you very much, Yves. I hope you can hear me. Yes, we can hear you. Thank you very much. This is my presentation. It is going to focus on aspects that directly affect DRC in terms of vaccine confidence and vaccine uptake. I'm sorry, I'm trying to move my presentation. Very well. This is the presentation's outline. I am going to have a few slides, so it's going to go very fast. Let's start with the background. I would like to remind you that DRC is a huge country, and due to that size, we have 26 provinces, and because of that size, the country has experienced a number of epidemics. One of the most well-known epidemic that we have known is Ebola. But what we've also experienced is that we have a very low vaccine coverage, 52.5%. And in 2016, our group, the GTCV, was set up and started operating in 2018. That being said, we have been experiencing a number of communication challenges, especially regarding the clinical trial of the COVID-19 vaccine. This was a problem because there was a piece of information that the country experienced, according to which the country was going to be the trial site for COVID vaccines. I have to say here that ever since the pandemic started, the authorities took matters into their hands in order to organize the response. And in terms of the organizations that were responsible, we have at the helm the presidency, which set up an advisors task force. The task force itself was made up of a response, a multi-sectoral response committee, which is chaired by the Prime Minister and whose secretariat is managed by someone who was appointed by the President of the Republic. I would like to also remind you that the country is extremely huge. And so what happens in the provinces is such that we need to be able to keep an eye on that. And in order to do that, we appointed incident managers who are responsible for operations in the various provinces, especially in terms of logistics. Under the incident manager, we have deputy incident managers,
dealt with communication and etc. And to give you an idea of the pandemic situation in the DRC, on this slide, we can see that so far, we have had 4 waves of the pandemic since the first case, which was declared in March 2020, the 10th of March 2020. Given the fact that there has been some sort of positive development of this pandemic in terms of the management of the pandemic this year, the management costs were brought down. We can see that on aggregate, on the 5th of April 2022, we had recorded 86,747 cases with 1,337 deaths. Some provinces are more affected than others, and the most affected are those that have a very important economic, a very active economy. And of course, we must mention the economic impact of the pandemic, which led to developing some sort of resilience, despite the fact that the GDP was severely affected. And talking about the uptake of vaccination, which is the main topic, I must say that there were some positives. We can then mention under the positive aspects the fact that in February 2021, vaccination was adopted. And as I mentioned previously, there was a working group that was established, and the intervention of this working group was then required, and that was during the first phase of vaccination, which was with the introduction of the AstraZeneca, Sinopharm, and Sputnik on the 5th of February 2021. And this working group was again called upon to give its opinion on the Pfizer, Moderna, Sinovac, and Johnson & Johnson vaccine, which was favorable. That opinion was then favorable, and it was given on the 23rd of August 2021. So for the year 2021-2022, the country received 1,810,000 doses of AstraZeneca vaccines. However, under the negative aspects, we can see that the awareness raising amongst the population on vaccination was very low, and this of course was exacerbated by the predominance of rumors and fake news. And added to that as well, there was the low compliance by the service providers, and the controversy around the AstraZeneca vaccine. It did not help the situation either. It was under the negative aspects. Following the opinion by the NITAG on 21st February 2021, there was then the launch of the vaccination campaign in Kinshasa with the AstraZeneca vaccine on the 19th of April 2021. And some doses of the vaccine had expired. Therefore, there was a requirement for new doses to be redeployed to the tune of 1,444,000. And sir, you have 2 minutes left. So this campaign was interrupted on the 10th July 2021, and these factors contributed to a low vaccine coverage in the country. The phase 2 it was launched on 23 August 2021. However, to this day, the vaccine coverage remains low as well. So what were the challenges that contributed to this low coverage? We have the low commitment by the public and the insufficient resources made available. The management of data was also an issue, and other factors. Confidence in the vaccine was quite negative. There was strong hesitancy to the tune of 30 to 40%. People interviewed said that COVID-19 vaccine was not safe, and they did not trust it. So in terms of the confidence, the majority expressed their lack of confidence towards the vaccine. Only 7% had confidence in the vaccine. And over half of the people interviewed were not sure if they wanted to get the jab. There were also a number of factors that exacerbated the doubt: low risk perception, the redeployment of the vaccine, and the low lack of interest by the authorities. There was also the interruption of the distribution of the AstraZeneca and the Johnson & Johnson vaccine. Of course, we can add to that conspiracy theories and miscommunication all around the issue. There were a number of challenges related to vaccination in the DRC, and to change the situation, there needs to be an improvement of the vaccine coverage. There needs to be an increase in the service usage. there must be sufficient provisioning and sufficient and continuous provisioning of vaccine. Wastage must be reduced, and resources must be made available, and misinformation must be fought. Ladies and gentlemen, thank you for your attention. Thank you, Mr. Paul, Professor Paul Lusamba, for sharing the DRC experience with us. We have taken good note of the various response measures deployed to deal with the COVID-19, and also issues related to confidence in the vaccine, as well as the various hesitancy factors. Thank you very much for that. I'd like now to invite Mr. Charles, Professor Charles from South Africa, for his presentation. Can you see my screen? Yes, we can see, and everything is now perfect.
Talk about COVID-19 vaccine confidence in South Africa, and this is going to be the plan of this presentation. So the NITAC in South Africa was established in 1994 following a review of the National Expanded Program on Immunization by the National Department of Health, together in collaboration with the WHO and UNICEF, and well, what is referred to as the Ministry of Health in other countries, we call it the National Department of Health in South Africa. So if I refer to the National Department of Health, it's the same thing as the Ministry of Health in other countries. But the aim of the National Immunization Technical Advisory Group in South Africa is similar to what is in other countries, to provide advice to the Minister of Health in everything related to vaccines and vaccination. So just before COVID, the National Immunization Technical Advisory Group in South Africa established a working group on vaccine hesitancy, which was expected to review the evidence and make recommendations to the National Department of Health on interventions to prevent and reduce vaccine hesitancy and increase demand in South Africa, on strategies to raise the pro-vaccine voice and strengthen vaccine advocacy in South Africa, on research priorities for vaccine hesitancy in South Africa, and on strategies for monitoring vaccine hesitancy in South Africa. And the working group did a review of the evidence on just before COVID came in, and the findings of this review from this working group were that vaccine hesitancy was an understudied topic in South Africa before the onset of COVID-19, and that vaccine hesitancy in South Africa is complex and dynamic social process that reflects multiple webs of influence, meaning, and logic. And it also concluded that vaccination views and practices of South Africans comprise an ongoing engagement that is contingent on unfolding personal and social circumstances, which can potentially change over time. And they made various recommendations, one of which was that the comprehensive public vaccine communication strategy, which disseminates timely, accurate, and transparent information about vaccines, should be developed and implemented. And then, of course, this was happening just at the time that COVID-19 set in, and most of this review was completed already when COVID-19 pandemic was there. And this slide shows the timeline of events in South Africa, at least during the first year of the COVID-19 pandemic. The first case in the country was recorded on the 5th of March, and the rest, as they say, is now history. So one of the structures that was put in place by the South African government is the Ministerial Advisory Committee on COVID-19 vaccines. Remember, I talked about the NITAC, but in South Africa, it was different structures were created to advise on COVID-19 response and COVID-19 vaccines. So the Ministerial Advisory Committee on COVID-19 was established in March 2020. The MAC was later reorganized for more efficient decision-making, bringing in more disciplines. And following this reorganization, the multi-sectorial Ministerial Advisory Committee for Social and Behavioral Change was launched on 16 June 2020. And then also after that, the MAC on coronavirus vaccine was established in September 2020. And talking about vaccine confidence and hesitancy in South Africa, even before the vaccines became available, in the middle of 2020, there were trials that were starting in South Africa, and there were already protests against vaccine trials in South Africa. And you can see these are photos from some of the protests against COVID-19 vaccine trials in South Africa, with a lot of misinformation in the posters that were shared. So about the time that COVID-19 vaccines became available in South Africa, an interministerial advisory committee technical working group on vaccine hesitancy was established and was tasked with developing an advisory for the Ministry of Health in South Africa. And these are screenshots from the publications on the evidence that was prepared by this interministerial advisory group. So what the interministerial advisory group on COVID-19 vaccine hesitancy in South Africa did was, the first thing they did was to search for and synthesize the evidence on surveys that were conducted in South Africa, looking at the willingness to receive COVID-19 vaccines. And what they found was that up to about July 2021, 12 surveys had been conducted, and they were these were of varying sizes, from about 400 participants to more than 75,000 participants. And 10 of these were actually nationally representative surveys. And I've just shown the screenshots of some of the survey reports here. So what we found looking at this view was that there was variability in the level of willingness to accept COVID-19 vaccines, from 52% in the one that found the lowest to 82%. And two of the very large nationally representative surveys showed that more than 7 in 10 adults in South Africa by the middle of last year were already either vaccinated or were willing to be vaccinated. We found that concerns about the safety and efficacy of COVID-19 vaccines were the main reasons for vaccine hesitancy, that only a small minority were swayed by conspiracy theories. And we also found that a range of social factors influenced vaccine acceptance in South Africa, and this included age, with younger people being less accepting of vaccines than older people, race, and location, and political factors. We also found that this would influence the willingness to receive COVID-19 vaccines. What also we found from these surveys was that the COVID-19 pandemic may actually be worsening the situation of vaccine hesitancy. But we found that beliefs that vaccines could be unsafe actually increased during the COVID-19 pandemic. So the conclusions we had from reviewing this evidence was that more attention needs to be placed on the concerns about the effectiveness and safety of COVID-19 vaccines that people have. And this could be done through vaccine literacy campaigns that provide factual and transparent information, including potential adverse events, where the evidence gaps are, and the uncertainties around COVID-19 vaccines. What we found also was that COVID-19 vaccine hesitancy is a complex social phenomenon, which is influenced by various factors. And we think that these factors should be taken into consideration when developing tailored interventions. And also what this working group said was that addressing interacting relationships that exist between COVID-19 COVID-19 vaccine hesitancy, and vaccine hesitancy more generally was very important. And they concluded that the pandemic provides a potential opportunity to positively intervene in more general vaccine hesitancy trends in South Africa. So when this evidence was synthesized, this was presented to this working group, the Interministerial Advisory Committee, a working group that prepared this evidence and then proposed an advisory, which the various ministerial advisory committees jointly submitted to the Minister of Health. The first one was on the 12th of April in 2021. And as the evidence, as more evidence was coming in, this working group again updated this systematic review towards the end of last year, and this advisory to the minister was updated. And in this advisory, there were various tailored interventions that were proposed, for including a vaccine literacy campaign, in creating an enabling environment to ensure that we increase vaccine confidence and reduce vaccine hesitancy in South Africa. Ngiyabonga. Merci beaucoup. What do you eat?
Merci beaucoup, professeur Charles. Vous êtes vraiment resté dans le temps.
Thank you very much, Professor Charles. You definitely stuck to the time allocated to give us an overview of the situation, the South African experience with the COVID-19 vaccine. And we saw that a number of bodies were established and some strategies were developed based on survey results which were conducted extensively around the country. And now we are going to listen to Professor Jahit, who is going to give us his presentation on the Mozambican experience.
Good afternoon, everybody. Professor Enes, I think you're hearing me well. The sound is good. And yes, okay. I will speak.
Oui, on vous entend. We can hear you, please.
Okay, I will present my presentation in Portuguese, but the slides is in English just because I think we have other people from the other speak Portuguese countries, and they would like to have my speak in Portuguese. Also, it's best for the translators do it in the best quality the translation. Eu vou apresentar a questão
I'll be making my presentation.
Hello? I can continue?
Yes.
Hello? Yeah, okay. Então, eu vou apresentar.
I'll be presenting.
Sobre o que está a acontecer em Moçambique em relação à vacina
on what's happening currently in Mozambique as concerns vaccine confidence and the COVID-19 vaccine.
Esta será a minha apresentação.
This is the structure of my presentation.
Em termos de vacinação, dizer que Moçambique começou a vacinar.
In terms of background, I would like to say that vaccination commenced in Mozambique in March 2021 in accordance with the National Vaccination Plan that was approved by the Council of Ministers. and also following all directives that we received from the WHO, and also all directives issued by the country for emergency use. The national plan considered the target group, and this target group was supposedly all people aged 15 years and older, a total therefore of 16,825,000 people. However, the vaccination has only been done amongst population or amongst people aged 18 and over. At the moment, we're still continuing with our vaccination campaigns in the country, and I'll be showing you the results a little later. Here are some milestones of our vaccination campaigns and some of the most important events during this time. The first case of the first COVID-19 case was reported on the 22nd of March 2020, followed by the first pediatric case on the 26th of April 2020, and the first death a month thereafter in Mozambique. The interesting information on vaccination is that we commenced vaccination in March 2021, about 12 months after the onset of the pandemic. And currently we're looking at the third dose for those people that have already taken their second dose. These are the epidemiological data that we have for Mozambique, which show that 2 days ago we only had 11 positive cases reported throughout the country. So currently we have only 50 in terms of gender. And we see that women seem to have suffered a little more than the men, although the difference is negligible. This is the information we received at various dates. And here we see that Mozambique has gone through 3 waves. The first at the start of 2021, the second halfway through last year, and then again at the end of this year. So these are the major waves, and our positivity rate is 17.3%. And in the last 2 months, we've recorded only less than 50 cases a day. An important issue here is the response preparation. And the outcomes in Mozambique have been quite positive, and this could be because of our high coverage rates and the preparation throughout the country. There was a technical and scientific committee that was established at ministerial level by the president. And we also created an emergency operational center at the Ministry of Health and at provincial level too. NITAG was also involved in preparing the response plans to the pandemic with a vaccination plan that is still underway. We trained several teams for rapid response. We also prepared several communication strategies, and I'll be showing you some documents. This communication strategy was aimed at sensitizing people as to the positive aspects of the vaccine. We have also expanded surveillance at all entry points into the country, so airports and harbors. We've also intensified epidemiological and laboratory surveillance, as well as research and investigation of suspected cases. We've also investigated outbreaks, and we identified specific hospitals to deal with COVID cases. So these are the preparations we undertook. Now, the population we targeted in the first phase in Mozambique, we started first with the health professionals, both in the public and military health professionals. Then we moved on to other health professionals. We moved on then to retired professionals, and then we moved on to the elderly people in homes, and then to the younger population. So these are steps that were introduced progressively in accordance with our vaccination plan. And some of the target population included patients with heart failure and chronic respiratory failure, and also policemen, etc. This table shows the coverage ratio throughout the country in all the provinces. Here we see that the coverage ratio on the 10 of April was about 89% in a population of about 12 million people that could be vaccinated. And according to the data we received the day before yesterday, we have about 89.1% of the population that has received the vaccination. So hesitancy in Mozambique is not really an issue and a problem that we have identified.
Unfortunately, we are not able to decipher whether this is a problem from the hesitancy part or whether it's a coverage problem. So what did we learn from our experience in this pandemic? We obviously learned that we have to use information technology to manage public health events. There's also a need to have a certain flexibility of our administrative processes in emergency situations. We also learned that we should involve the leaders in the management and advocacy at all levels. I'm almost finished, says the gentleman. In terms of challenges, we need to use unplanned resources. There were some resources that were used and that we had no idea that they were going to be used. We learned as we went along, and there was also a lack of funds for operationalization of activities, for example, how to transport our samples, but we learned with time and with our experiences. We also did a surveillance or a study at community level, but we did it very vigorously. We started articulating and corresponding with various communities, showing how the pandemic was happening. We showed them what the results were after the vaccination. We dealt with the stigma. We started tracing the contacts that were difficult to trace. We also saw that during the pandemic, there was a large reduction in the flow of patients. And we also saw that some people provided incorrect names. The other challenges were lack of funds for operationalizing the activities, but I've already told you that. Another challenge was at various times, there was a huge shortage of reagents of our products. We also found that it was a little bit difficult to transport vaccinations to various places. We now have 9 million dosages of vaccines that are still to be administered in Mozambique. So what are going to be the next steps? We are going to try and maintain the present coordination between the different communities, between the different groups, so that we can continue with this pace and this rhythm of vaccination. We are going to try and change and make more efficient the interoperability aspect between the different systems that we use. We are going to also allocate cell phones and tablets to those 1 million odd people that still haven't been vaccinated. We're going to implement the subsystem of hospitalization, and we are going to do all of this based on evidence. And of course, we are going to continue to vaccinate against coronavirus. We haven't started vaccinating our minors. We are only vaccinating from 18 years above. And here are all the documents that we have prepared to make people aware of the need to vaccinate. We are now concluded the second dose. We are now starting with the third dose of the vaccine. Thank you very much.
Merci beaucoup, Professeur.
Thank you very much, Professor.
Diapositive.
I think this was indeed your last slide.
Merci beaucoup, Professeur Jaït. Merci pour avoir partagé.
Thank you very much, Professor Jaid, and thank you for having shared the good results that Mozambique experienced. We are a few minutes late, and in order to catch up with time, we're going to continue directly with the last presentation, which is going to be made by Dr. Conan, who is the chairperson of GCTV Zimbabwe. Professor, you have the floor for the next 10 minutes. Thank you.
Thank you very much.
In the meantime, you could also put your questions in the Q&A in the chat box. You can go ahead. Professor, we can hear you. You can go ahead.
Yes, Chantal, you got my slides. These slides we prepared together with the other members of the Zim NITAG Secretariat, which include the technical partners, UNICEF and the World Health Organization, and also our EPI manager. And at this point, I must also make a point that the government of Zimbabwe has actually created a parallel structure, like we saw in the South African presentation, which is looking at the major decisions about choosing the COVID-19 vaccines. We call ours the Expert Advisory Committee on the COVID-19 vaccines. So, okay, as an introduction, Zimbabwe was one of the first countries. Hello? I think I'm having problems with one of my... Zimbabwe was one of the first countries to start COVID-19 vaccination. We commenced on the 22nd of January 2021 as part of the national strategy to fight COVID-19. We had the launch from our Minister of Health and also from the President himself. And we also had several provincial launches done by the provincial medical directors and their team. Next slide, please, Chantel. The vaccination was rolled out in phases. We started with the health workers, social workers, security sector, and other frontline workers. Obviously, at the beginning, this didn't work out the way we had planned because it was actually the health workers who were initially quite hesitant. Although it was clearly indicated how we should be prioritizing our rollouts. So other people who could access were jumping the queue really and going to be vaccinated. The health workers, I think initially, they were very, very reluctant to get vaccinated. Things changed obviously when we started having a lot of deaths from the Delta wave. That's when we really saw an increase in all sectors of people coming for vaccination. We have started vaccinating 16 to 17-year-olds. This was a request really from the Expert Advisory Committee and the government itself through the parliamentarians who said that they really wanted Zimbabwe to start vaccinating children. At the moment, we have actually recommended that vaccination of younger children starts from the age of 12 years. I'll talk about that later on because there are some issues concerning the lower age groups. Again, we also had guidance on vaccination of pregnant and lactating women. And yes, the decision was these women should not be excluded, but they should be offered vaccine as long as they sign an informed consent form. It is also the same with the young age groups, 12 to 15 and then 16 to 17. There has to be a consent. Next slide. This is just a slide which is showing you by province the target population. Then you have the first dose percentage that have been vaccinated. If you just look at and concentrate on the figures at the bottom, those are the national figures, 11.2 million, 50.4% have got the first dose. Second dose, 31, and the booster dose, the figures have gone down to 4.6%. There could be several factors related to this. And one of them obviously was the Omicron, which came, and people now know that Omicron is not as devastating as for instance, the Delta variant, which caused a lot of mortality. So a lot of people are really getting reluctant to get vaccinated, especially when they receive the CIT-REP figures every day. Most people do receive these figures on their telephones as messages. And people will see that the cases are very low. They know there's Omicron, which is acting more like a vaccine. And people are really getting very reluctant to get vaccinated. Next slide.
So again, this is another slide showing you the total doses that have been administered and the vaccine doses that have been received. So we've got a lot of vaccine that is around. And one of the problems that we are now facing is actually running out of a cold chain space for keeping those 16 million vaccines. Our vaccine utilization is standing at 42%. Next slide. Best practices and enablers. Development of a national deployment and vaccination plan. We know very well there's a very strong political support and commitment. We have been acquiring our 4 vaccines. This is Sinopharm, Sinovac, Sputnik, limited amounts though, and the Covaxin, again, we are not getting a lot of that at the moment. I think there's been some suspension of from actually at the manufacturer level. Health workers have been trained at all levels, and we've been using a lot of Zoom trainings. And there's also been a lot of demand generation strategy and implementation at national level. Intensive media blitz in different languages using radio. And that has been, we think has been effective, because tune on any radio station, which we have several, and also TVs, there will be a lot of jingles about encouraging people to go for vaccination. Continuous monitoring, support and supervision to provinces and districts. Multi-stakeholder involvement, the partnership and collaborations. Involvement and participation of local leaderships. We believe you need to go down and engage the chiefs, the village heads, and religious leaders and the councillors. Periodic local vaccination intensification activities. Again, all these things are ongoing and synergizing together. Next slide. Timely response to rumors, misinformation. It has been happening. We have a team at national level and also at provincial level that do respond either as interviews to some of these misinformation and infodemics. Integration of COVID-19 vaccination with other programs like routine immunization, OI, ORT clinics, family planning, OPD, and clinic for chronic conditions. This has happened effectively in other provinces or districts, and we don't know exactly what impact it is having on the whole COVID-19 vaccination program. Decentralization of vaccination to all public health facilities. Next slide. The private sector and the uniformed forces in vaccination. Initially, all vaccination was limited to government institutions, but all private players can only vaccinate using the government acquired vaccines, which is mainly Sinopharm and Sinovac. I think Covaxin and Sputnik, we might as well just put them aside. It's mainly those two. And the private sector is allowed to charge because they haven't procured these things. These vaccines will have been procured by the government itself. So they're just using the private sector facility to increase the coverage and uptake. So they are given a stipulated minimal charge that they should charge the client. Anything above that will constitute a criminal offense. So this has happened, and it is currently happening. And I think it has played a huge role in making sure certain type of people, classes of people also access these vaccines, but you cannot get anything outside Sinopharm or Sinovac. Researches and reviews to guide program implementation. Yes, we've got underway a COVID-19 vaccine effectiveness study. And actually, what we know at the moment is we follow the national guidelines. I mean, the global guidelines, we look at them and try to adopt them as we do in NITAGs into our local situation. We don't know whether we should be having a fourth dose, for instance. We don't know how effective, we don't know how many more vaccines are going to be necessary, even to those that got their first 2 doses. But looking at the uptake of the 3rd dose, I think we need a lot of guidance in terms of what is actually happening. Rapid assessment, tackling gender-related and operational barriers to equitable COVID-19 vaccine development, and access to COVID-19 vaccinations by the most marginalized. Again, these are some of the things that we think can help in terms of increasing the uptake. Next slide. So those are the challenges. I think they are not unique to Zimbabwe, and some of them we've obviously seen them in the other presentations, and also in the first one that was done by Lisa. The myths, misconceptions, misinformation, infodemics. We are having a problem with our cold chain storage space with those 16 million doses, and currently with the very low uptake. So at some point, one of the messages from our principals was this: we cannot waste these vaccines. They are about to expire. Please, let's vaccinate as many children as possible. I think it's fair to say this is the pressure we had, but we were looking at it from a technical point of view. So we did not succumb to that pressure when we reduced our vaccination age to 12 years and above. We were working with what we thought was technically sound. Although in terms of prioritization—
Please, Dr. Guna, can you conclude?
The children are still at the lowest risk in terms of acquiring COVID-19. Shortage of health care workers, fatigue, lack of microplans at all level, poor data management. Sometimes we would run out of vaccination cards, and again, hard to reach areas, and stock management, logistical support, fuels, vehicles, and all those are some of the challenges. Next slide, I think we're almost done. Way forward to intensify vaccination, integrate it with routine immunization, increase number of outreach, target certain populations, bottom-up approach to planning, starting with micro plans at health facility, to strengthen existing ordering system based on usage, distribution, and stock management. Strengthen community involvement, participation, facilitate timely availability of data, and also IEC material to include 16 and 18-year-olds, and updating the material. I think, let's have the next slide. I think that's the last one. Thank you. That's all I have to share with you. It's just an insight. There's more that is happening, but thank you for giving us the opportunity. Thank you very much.
Merci beaucoup, Dr. Guna.
Thank you very much, Dr. Guna. Dear participants, I think we were able to listen to 4 various country experiences. All those experiences were very rich, very diverse, and we now have only 7 minutes for debate. My suggestion is that you continue asking your questions in the chat, and the organizers are going to try and answer them. We are going to use the following 7 minutes to answer a few of the questions. Now, for those of you who would like to ask questions, please raise your hands. But in the meantime, we already have a number of questions that have been asked in the Q&A. One of them is to try and find out if some work was already done in terms of vaccine acceptance by health workers. And if that is the case, would it be possible to share the links towards such research and such studies for the delegate that asked the question? Now, regarding the last presentation by Zimbabwe, I think there is one delegate who wanted to find out if Zimbabwe was the first country to have started vaccination on the continent. Now, let's see if there are any hands that are raised. I see one. I see CD who raised their hand. But before I give the floor to CD, I'd like to ask Professor Jahid. This is my question. Given the good performance that you've experienced, that Mozambique experienced in terms of vaccine coverage, could you tell us what key characteristics do you think contributed to such good overall performance? Since we're here to share experience, we would love to hear your opinion on that. Professor Jahid, did you understand the question?
I understand the question. I can respond in English. Yeah, I think it's two main points. One is involvement of our president in all this process, also included in the ask for other countries, European countries, partner countries to give us the vaccines. I think this is the first, because he did a lot to find collaboration and partners to have vaccines. I think another important point is how is the country is structured in terms of health system. I think is help us to give more impact. Also, all this communication that we give to the population using the televisions, radio, and other ways, I think is important to doing this very well. Coverage that we have now. The number is still high, continue also for booster dose. Many people from here in Mozambique can continue to vaccinate, and we have a lot of vaccines in the country, and we still continue to communicate and vaccinate for all the country. I think this is the main reaction for this very good coverage that we have. Thank you.
Merci infiniment, professeur.
Merci. Thank you very much. Thank you very much, Professor, for having shared that experience. Without further ado, I will now give the floor to CD.
CD, tu as la parole, s'il te plaît.
CD, you have the floor. Thank you very much. Thank you once again to Dr. Lisa Manning, as well as to our 4 presenters for their various presentations. The presentations that were made from Mozambique, DRC, Zimbabwe, and South Africa. Sidi, you only have 2 minutes to finish. Okay, thank you very much. Let me go quickly. In the presentations, we heard about the various challenges that the countries had in terms of vaccine acceptance. We saw, for example, that in South Africa, NITAG played a role and was more involved. The question is, what is the exact role played by NITAG in Mozambique, Zimbabwe, and DRC in terms of advice to the various ministries of health, and more specifically in terms of demand generation in COVID-19 vaccines demand generation? To finish off, I think there are a number of NITAG representatives in this meeting, and I think they can also continue with my question. The second question is, what is the level of recommendation in terms of the booster doses? And what is your opinion in terms of the vaccination for children aged 12 to 17? And what are the main recommendations that were developed by the various NITAGs to enable ministries of health to improve vaccine coverage? Finally, I would like to advocate more with NITAG secretariats and representatives so that we may have more representatives and members of NITAGs participating in such meetings, because everything that was done in Africa to support NITAGs in evidence generation should continue, and we should be able to have higher quality recommendations. For you, I believe it is important to be able to use that and to involve more members of NITAGs as well as the country teams. You have the floor. Thank you very much, Dr. Sidi. I think your call was heard. I think everyone heard you very loud and clear, and GCTVs should be informed, should receive the links, and should share the information. I am now going to give the floor to two participants who also raised their hands, and following that, we are going to start with this session. We've already gone beyond the allocated time. Chantal?
Chantal?
I've allowed the two attendees to speak.
Okay.
So you can call on whichever you prefer to speak first.
I can't see them, so the first can speak. Yeah.
I see there is Ibrahim and Al-Kasum. So Ibrahim, maybe you start. You go first.
Please. Okay. Ibrahim, please go ahead. 1 minute, s'il vous plaît.
1 minute, please.
Je crois que Ibrahim a certainement de soucis avec son micro. On peut passer la parole à la deuxième personne, s'il vous plaît. Chantal, the second person, please. The second participant.
Voilà, le deuxième participant qui a demandé la parole peut l'avoir maintenant.
Okay. Let us conclude this session so that
Et essayons donc de conclure cette session.
Oui, pour ne pas vraiment creuser trop le retard.
To avoid being delayed further.
Have we lost the interpreters, Yves? I see their hands are up.
No, he has already spoken.
Ils ont déjà parlé, ils ont déjà pris la parole.
Sidi a déjà parlé, Benjamin.
Barbara,
O Sr. City já interveio, Benjamin.
Barbara?
Yes, the interpreters should still work. Just let me check. I don't know. I haven't heard anything else.
Barbara, I can't hear you. D'accord. Donc, chers participants,
and I don't know what it is because
well, dear participants.
Can you hear me?
Okay. Looks like the interpreters are working.
Interpretation is working fine. The speaker, the current speaker, must be on the wrong channel. So I wanted to thank all four presenters for sharing their experience with us, a respective experience with us. And we were able to appreciate the fact that vaccine acceptance is still an issue on the African continent, and it is very important to envisage and to come up with strategies which are based on the results of studies in order to overcome the obstacles that prevent us from achieving better vaccine coverage. Even when it's difficult for countries to reach the 10% for June 2022, it's very important to target all vulnerable populations and vaccinate them. And the vulnerable populations are those that are unemployed and those that are in the front line. And those are some of the points that I wished to highlight in conclusion as I'm concluding this session. We have exceeded the time by about 5 minutes. We apologize for that. So organizers, you have the floor again. Thank you.
We'll have Promise present.
Thank you so much, and greetings everyone. I'm just going to switch on my video for a second just to greet everyone and switch it off to save bandwidth. And again, let me extend my appreciation to the organizers of this webinar, for allowing me this opportunity to be part of this very important discussion. And I think also just to thank the previous presenters for, I think, what they've managed to do from my side is really rightfully set the tone for the presentation that I'm basically going to make. I think there is a lot has been discussed amongst the key themes that I saw emerging is the idea around, you know, the need to strengthen systems for evidence use in decision making around vaccine uptake, in light of the research that is available. In light of the high amount of research that is available around this topic. And basically, this is just the outline of my presentation. In simple terms, it's all about evidence and decision making. That is the key focus of my presentation, and how we can support the NITAGs in terms of decision making. And whilst there are numerous questions that emerge based on the discussions and the presentation that have been made on this topic, I'll basically focus on on how we can gather evidence on the relationship between vaccine COVID-19 and vaccine uptake in Africa. So initially, I'll present on evidence mapping broadly, which is an activity that we as Africa Center of Evidence are collaborating with Nanish at University of Cape Town in developing and as a support tool for the NITACs in decision making. One point up front, when we're talking about evidence map, we are not talking about these type of maps. We are basically talking about research maps, and I'll just discuss more about these in the next 2 slides here, but just to highlight the maps that we are basically discussing here, as I've indicated, it's about research maps in which we based on an area of interest or a research topic, we basically structure an evidence base or research evidence on a particular topic in a matrix framework, where you have on the left-hand side, in quotes, interventions, and on the right-hand side, the outcomes. And just to highlight another example based on an evidence map that we produced a few years ago, just to put across the idea around trying to understand what evidence mapping is basically about. And again, the emphasis around what is it that we're talking about when it comes to evidence mapping is structuring research around a particular topic in a matrix framework. For example, in this case, when you're looking at evidence on what works to improve female wage labor market participation in low and medium income countries, on this y-axis we have the respective interventions that were mapped against outcomes of interest on the x-axis, or on the top right axis. And what then eventually as a product try to do is to place the research that we would have gathered from connecting systematic searches, screening, and data extraction in a structure that is meaningful and consumable. And is what you see basically here in the highlights where the evidence will be placed, evidence that falls within the criteria that would have been developed in structuring it within the matrix framework. For instance, here you'd see that the existence of a bubble here basically means there is existence of evidence around conditional cash transfers that have employment statuses, and anything that doesn't fall within the criteria that would have set will not make it in the map. For example, what falls outside here. And I'll share again a specific activity or evidence map that is being developed around COVID confidence and vaccine confidence and uptake in Africa in live version as I continue. And just to highlight again, in trying to understand what evidence mapping is all about, there is a technical definition and empirical definition around it, but we will just focus on the empirical definition of, or more practical definition of what evidence mapping is basically all about. And really, it's really about identification. It's about providing a systematic approach to searching for evidence on a particular area of interest, and present this evidence in a figure or table, an online database that allows for, amongst other things, identification of gaps in the research, and more importantly, it's about stakeholder engagement in a user-friendly manner. So the premise that we work on when you're developing evidence map is to assume that there is a lot of research out there around a particular topic of interest, and there's so much primary studies as there is a lot of crops in a field, and evidence map are basically about sourcing, organizing, and visualizing a body of evidence around a particular topic of interest, as in the case that we are facing here, where I'm going to provide an example around vaccine confidence and COVID-19 vaccine uptake in Africa. And contextually, just to put this across, that evidence maps are really, there's different ways of making sense of a body of knowledge, and evidence map are only one part of these. We have the gold standard, which is systematic reviews, and to emphasize that systematic evidence map follow the principles of systematic reviews in developing these. Then we also have literature reviews that have limitations, such as the fact that maybe experts who only pre-select studies that conform to their viewpoints that they have. And we have rapid assessments. Again, they follow basically these principles of systematic reviews, but they're quite fast, quick, and actually might miss the detail. So just to put that point across, where evidence maps lie within the ecosystem of different ways of trying to make sense of a body of knowledge. And what are the key steps of evidence mapping? I would really not go much into detail with all these steps, but just to highlight provide an overview of the key steps, especially in light of the fact that we need to emphasize that evidence map really follows the principles of systematic review, starting from clarifying the scope of the question by engaging different stakeholders. And a key important output of this process is developing a conceptual framework. That is basically what I'm also going to highlight again when I demonstrate through a live map what this basically means. Is basically deciding on the structure of the map in terms of what really goes on the y-axis and what goes on the x-axis. And then we go on to look for that evidence systematically and screen, and then gather information, relevant information that will allow us to visualize this map through a coding exercise. And in some cases, we appraise this evidence, and more importantly, we do a visualization of this evidence after it has been data extracted, or after relevant key variables have been gathered from this evidence base. And more importantly, it's about engaging stakeholders. And following this, I'm going to basically speak to, firstly, highlight the framework that has been developed in the activities that are going in between the Africa Center for Evidence and the University of Cape Town in a visualization format. So basically step 1 and step 5. And this is basically a snapshot of an area that we are focusing on, particularly for this map, which is basically around understanding the size and the nature of the relationship between vaccine confidence and COVID-19 vaccine uptake. And to re-emphasize this point around the fact that there is so much information and research that is being produced around COVID-19 from different angles or different focus areas. But in this particular case, this is the proposed structure of the evidence map that focuses on the size and nature of the relationship between vaccine confidence and COVID-19 uptake. And this is the conceptual framework of the structure, basically where you have on the y-axis here, what we call interventions, in quotes. We have elements around descriptive data about vaccine coverage, sensitization and educational campaigns, reminders as interventions in terms of trying to understand the size and nature of the evidence on this relationship. And these are the proposed outcomes, highlighting aspects around implementation, confidence rates, vaccine availability, and all these have sub themes on them. So this is the proposed structure. It's not cut in stone, and in a way we might want to take this as an invitation to join this journey in terms of developing this structure depending on the needs of NITAGs, but essentially this is about providing an evidence base that aims to support the NITAGs in terms of decision making, with a full understanding of this area of interest. So that's brings me to the end of the presentation, but allow me to take this opportunity to quickly show you the map in live version. This is an interactive map, and as I've highlighted, how this is the reason why we really quite like to focus on the practical definition of an evidence map, the user engagement aspect of it, the online, the database around it, and evidence base to support decision making. And this is basically a live map based on that is more or less similar to the snapshot that we've provided. So in a live version of this map, this is how it will function, where firstly, we have this structure that I've just shown here, and the existence of bubbles at any point of intersection reflects the availability of evidence for that particular intervention and outcome configuration. So for instance, just to highlight here, this study would speak to descriptive data about vaccine coverage and an outcome. It looks at vaccination confidence rates. And as you hover around this map, as I'm doing now, it shows you the amount of evidence that is available on the particular area. And what it also does, it reflects the gaps that exist in terms of the research around the particular area of interest. This is just an example with a few studies. After comprehensive systematic searches, it would have more studies and to highlight points of saturation and other gaps. So that's how the map functions at this point. And just to highlight other interesting functionalities is basically how we can tailor this map in terms of visualization. It can be changed to visualize it differently, the bubbles, and also to highlight that the size of the bubbles within in that intervention outcome intersection reflects the amount of evidence that is basically available. Just to quickly highlight, as you can see here, for this intervention outcome intersection, there's basically two bubbles. That's why it's bigger than a situation that is here. And amongst the other key functionalities is the ability for us to separate this evidence from a visualization point of view, depending on the attribute of interest. So in this case, as an example, we actually divided the evidence based on how equity, how it considers equity in its research. As you can see here, that reflects the different coloring. We have studies that have equity sensitive approaches, and some studies that just acknowledge equity, and those that are equity blind with these different colors, the orange speaking to equity blind and the blue speaking to equity acknowledgement. Different attributes, different variables can actually be used to separate this evidence depending on user interest. But just to highlight again some of the interesting features, you could separate this evidence by some of these attributes, including region or the context in where the research was conducted. So for instance, as this map is focused on Africa, you could be able to separate between regional demarcations such as Southern Africa, Western Africa, and also be able to separate on a country level as well, as this information can actually be extracted from this study. So this brings me to the end of this presentation in light of the time constraint. And thank you so much for listening. And again, to invite you to this journey as we develop a map that is useful for decision making by the NITACs. Thank you so much, Chair, and thank you to the organizers.
Thank you so much, Promise, for this, and just to mention to NITACs that evidence gap maps of what Promise has presented is one of the tools that, as a project, we're thinking could help the work of NITACs. And the very first map is on COVID-19 vaccine confidence in Africa. And we would want to get participation of NITACs in the creation of this map so that it's of good use to nitrates. And the idea is that if this is relevant and it's useful to nitrates, we could develop other maps, which will obviously be identified in terms of topics by nitrates themselves. So maybe I'll take this opportunity to say that those nitrates who are in this meeting and feel that your country would want to be involved in co-creating these evidence gap maps with us, please let us know, because once we reach a stage of this of the development that can allow the involvement of nitrates, we would want to reach out to you so that we can work with these maps together. Maybe we've got a couple of minutes. If we can get feedback from nitrates on how they feel about these maps. I know it was quite short, but we would appreciate to hear your reaction, 1 or 2 comments from the floor on how you feel, or if you have any question about these maps. Anyone? You could type a chat or raise your hand and tell us what you think. Okay, no. Charles?
There is a question from, there's a question from Anonymous in the question and answer. It says, how does the map capture the types and interventions highlighted in the first presentation?
Charles, yeah. I can't hear you. Are you speaking?
Yes, can I just jump in, Chair?
Sure.
Yeah, so I'm actually looking at the questions that are coming through, and yeah, Charles is referring to the question from Anonymous: how does the map capture the type of interventions highlighted in the first presentation? So a quick response would be, without necessarily recalling the interventions that were highlighted in the first presentation, but I think essentially we would have to look at what components we have within this map here, and the different facets of interventions, and see if they meet that criteria. Then they can be captured within that map. And as I've highlighted, this is not the map in terms of the structure framework. It's not cut in stone. It's open for discussion and amendment, so it can be tailored to the specific needs of stakeholders. And be included. And I have a question here from Bero in terms of please explain the definitional difference between equity when it is acknowledged and blind. So essentially when there's equity blindness, I think overall equity consideration has become a very important aspect when it comes to developing this map. And then when a study is equity blind, basically it's not in one form or the other stating any equity consideration in any form. It could be maybe a study does not target a specific vulnerable group, or doesn't conduct a subgroup analysis or heterogeneity analysis, some of the ways in which equity can be considered. And in the absence of doing also that, it could be that a study does not really focus on this, but acknowledge how perhaps equity needed to be considered, or how it affects possibly the impact of a particular intervention. Thank you. Over to you, Chair. Thank you so much.
Thank you, Promise. We will reach out to NITAGs on asking or requesting those who would want to join us in co-developing these evidence gap maps with University of Johannesburg, who is our collaborator on this work, to be able to work with us. And I think we're now running out of time. I would like to, I see there's a comment in the chat. In Seychelles, we have anti-vax campaigners active on social media and some Christian religious groups. However, we do a lot of health promotion using all media. That's good. Seychelles, if you want to join us in the co-development of evidence gap maps, please, we will reach out to all NITAGs requesting for those who are interested. And in addition to evidence gap maps, we're developing a library guide, which is going to contain all the vaccine relevant information for the continent, stratified by country. And the idea is to make the information much easier to access and making evidence search much more efficient for NITAGs. Also, we're developing an information portal that will use dashboard and interactive map to indicate the kind of evidence that is available and relevant to the work of NITAGs. But I think what we've decided and seen as important for this project is that every product that we develop for use by NITAGs, we want to co-develop with you. And the idea is to create a framework to do that. And finally, in terms of the topics for the webinars, it's something that would encourage you to submit to us whatever topic that you feel you'd want to be covered by us. And we are going to take into considerations the topics of interest, and we make sure that these webinars are serving the purpose of bringing up-to-date information on vaccines and evidence-informed decision-making that is relevant to the work of NITAGs. With that, I would like to thank all the presenters and the participation of everybody, and to say that we look forward to engaging with you more in our next webinar, the topic to be decided, and you are part of the team deciding on the topics. So please send that to us. And to our moderator today, Yves, you've done an excellent job. Thank you so much. And we look forward to connecting with everybody at some stage later. Thank you all and have a very good Easter weekend. Bye.
Thank you.
Bye-bye, thank you.